Hi everyone, my name's Katie Pryor. I'm the Manager of Education Programs here at the Western New South Wales PHN. And I'd like to warmly welcome you all on behalf of the Western New South Wales PHN and the Education team and Kidney Health Australia to Understanding Chronic Kidney Disease for Aboriginal and Torres Strait Islander health workers and practitioners webinar. I'd now like to introduce you to Trixie Watts, who is a Primary Health Program Officer here at Western New South Wales PHN, to open the meeting for us. Thank you, Trixie.
Firstly, I'd like to start the meeting by acknowledging the Wiradjuri Nation as Dubbo today. I would also like to acknowledge that we work on the traditional lands of many Aboriginal clans and nations and pay my respects to elders past, present and emerging, and acknowledge the continuing connections to land, water and culture and their ongoing contribution to help shape the lives of our communities in which we all work, live and learn. And I'd like to have say warm welcome to all Aboriginal and Torres Strait Islander peoples here today, and hope we enjoy the webinar. Thank you.
I'm really pleased to introduce you all to Dr. James Collett, who you may have heard from previously. He does lots of sessions for our team and we really appreciate his support. Dr. Collett is a nephrologist and general physician working with the Western New South Wales Local Health District. He completed his specialist training in Sydney and Darwin and moved to Dubbo in 2017 to begin his career as a specialist. He has a strong passion for renal medicine and delivering high quality kidney and medical care to people in regional and rural Australia. And James, I'll now pass over to you to start today's webinar. Thank you so much.
Thanks, Katie. Let me just share my screen. You know, as health practitioners, you guys play a huge role in really trying to get primary prevention out there and getting people to see doctors earlier and picking up kidney disease earlier, because it's well known that the earlier you pick this stuff up, the more we can do to prevent people ending up on dialysis. So really crucial work, and I'm really appreciative of you guys all joining today. This is a talk that's done through Kidney Health Australia. Kidney Health Australia is a fantastic body for Australia, and they've got a lot of amazing resources online. If you just Google Kidney Health Australia, there's some excellent stuff there. They've got apps, they've got all sorts of things, and it's a really good place to point patients towards. So I encourage you to jump online and have a look at that website, because there's some really good stuff, and they've really tried to accommodate the cultural aspect of Indigenous Australians and have material specifically that's been designed by and for Aboriginal people. So yeah, really good resource there. I'll probably skip over that slide, and I just quickly wanted to also acknowledge the land that I'm on as Wiradjuri land. I'm actually in Mudgee today, but live and work in Dubbo, and just pay my respect to the elders past and present, and just say how lucky and privileged I am to live and work on such beautiful land, and how grateful I am. And I should say, with all these talks, I'm more than happy for you to interrupt. We've got the chat and monitoring that. So if you've got a burning question, please interrupt. I think these sessions are always good if we can have a discussion about things. There's no wrong questions, there's no wrong answers. It's just about discussing openly things, because you know, you guys see this stuff a lot, and it's good to get any burning things off your chest. But really today, what I wanted to cover was talk about chronic kidney disease and how it predominantly can be more of a problem in the Indigenous community, and ways around that we try and keep an eye on that, and what you can do in terms of detecting chronic kidney disease, and trying to just explain some of the stuff we use to explain kidney disease, so you can then take that info and turn it into usable information for patients. Because I often find that I'm trying to explain something to patients and they have no idea what I'm talking about, and you guys are a really good interface often with trying to make it understandable to patients, which I think we can do a lot more work at, and making sure that patients understand this stuff. So really, your role in chronic kidney disease is reducing the impact of chronic kidney disease. So picking up early, educating patients, identifying risk factors that put people at risk of kidney disease, encouraging, good lifestyle choices, because as they always say, healthy life equals a healthy kidney. And then, simple things like avoiding certain medications which can affect the kidney, and picking up on that stuff early so that we're all working together to look after everyone's kidneys. And I'm sure you guys know this, but just a little summary of what the kidneys do. I think, this is a pretty complicated diagram, but the kidneys are about the size of your fist, and they sit in your back on both sides in your flank. And they're pretty clever little things. They get about they clean about 180 litres of blood every day. And their job really is to make sure that you always have the same amount of fluid in your body, so you don't build up fluid. And the job is also to clean the blood and pass out urine, that's the stuff you don't need, so that all the cells in your body can keep working at the optimum level. And I often compare the kidneys to like the pool filter of a pool. If the pool filter doesn't work, the pool can overflow and you need to backwash it. And the pool can go green if the filter doesn't work. And that's like the kidneys. The kidneys are the pool filter of the body. They keep the blood at the right color, they keep the toxins out, and they keep the fluid at the right level at all times. The other thing that they do that often people don't realize is they're really important in your bone health. They help control something called your vitamin D levels. And so if you don't have good kidneys, your bones aren't very good. And they also actually help you make blood. Kidneys release a hormone called EPO, and that tells your body to make blood cells so you can carry oxygen around your body. And the kidneys are really important with that. So if your kidneys don't work, you can't do that. So you can get something called anemia, where you have a low blood count. So the kidneys do all these little things, and they're sort of the unsung hero of the body. They just work away in the background and basically are there to keep everything operating at an optimum level at all times. And they're interesting organs because people can lose a lot of kidney function without actually feeling any different. So that's why, as a kidney doctor, I'm very reliant early on kidney tests like the blood and the urine tests, because patients won't come to you often and say, oh, I feel like I've got kidney disease, because it's often the kidney has a lot of reserve. And I've seen a lot of patients that, drop from normal kidney function to 5% kidney function before they even realise. So that's why these kidney health checks and making sure people are aware of their kidney health are really important, because unless people get checked up, they won't know they've got kidney disease until sometimes they need dialysis. So it's really important that we monitor this stuff. The kidney, I don't want to go into too much detail here because it's, not a science lecture, which will probably put you to sleep, especially at lunchtime. But the kidney has about 1 million, there's about 500,000 of these little things called nephrons in each kidney. And the nephron is what we call the functional unit of the kidney. The blood goes in at one end, and basically gets squeezed through a little bowl, and all the junk gets filtered out and peed out. And sometimes you might hear as someone like me being called a nephrologist, and that's why, because nephron is part of the kidney. But I just say kidney specialist because it's easier, and people say, what is a nephrologist? But that's where the name nephrologist or kidney specialist comes from. And then this just says that. So inside each kidney, there are about 1 million tiny units, and they act as filters. And most kidney diseases damage those nephrons, and then the kidney stops working because it can't filter blood. And there's lots of different kidney diseases that can damage the kidneys, but the ones that are most common, especially in Aboriginal people, are high blood pressure and diabetes. They're probably responsible for over half of the people that are on dialysis. So, you know, a lot of people have diabetes and high blood pressure, and they're the two biggest risk factors for getting kidney disease. And diabetes and high blood pressure damage the kidney, and they stop the kidney from working. So there are other weird and wonderful diseases that can do it, but, you know, common things occur commonly. That's what we always say. So diabetes, high blood pressure, they're the two big things. And we often talk about this thing, chronic kidney disease. Chronic kidney disease has a definition, and all that means is when we do a blood test, we get a measure called your GFR, or your glomerular filtration rate. And really that's just a percentage of how well your kidney's working. And really anyone with a kidney function less than 60% on a couple of blood tests, usually 3 months apart, we say yes, they have chronic kidney disease. Someone might have normal kidney function in the blood test, but they might have other signs of kidney disease. So they might get protein in the urine. Protein in the urine isn't normal, and that their word there they've used is albuminuria, but that's abnormal. Or you could have blood in your urine, or the kidneys might look funny. Sometimes I see patients who get sent to me because they've had a scan of their tummy for a different reason. They've only got one kidney. So those people might have good kidney function, but they still have chronic kidney disease because they've got a structural problem with their kidneys. So that's the two things that define kidney disease, chronic kidney disease: someone with a kidney function less than 60% over a couple of months, or they've got markers of other evidence of kidney disease, like their kidneys look funny, or they've got protein or blood in the urine, which isn't normal. And I think this is a really important slide, and it's what I was saying before, is that kidney disease is often what we call asymptomatic, or people just don't know they've got it. So you can lose up to 90% of kidney function, especially young patients I see who are otherwise well. They don't even know they've got kidney disease, and that's why we often talk about getting annual kidney checks in people with kidney risk factors. And so we will go through those risk factors in a little bit, but you know, it's a bit of a worry, because sometimes patients may not even know they've got kidney disease, and then suddenly I'm meeting someone and saying to them, oh look, we've got to put you on dialysis and clean your blood because your kidneys don't work. And what we want to do is pick up those patients much earlier, so they can meet us and we can plan for all that, and it's not a shock, and we can do everything possible to stop it happening in the first place. And the only way we can do that is looking out for the people that we think might be at risk of having kidney disease and getting them to see their GP early. Or are you guys even saying, look, go and get your blood pressure checked, you guys can check it, you know, get a blood test, let's look at what's in your urine, because if they've got those markers, we can send them to kidney doctors earlier, and we can prevent this vicious cycle. And you know, you know, we're trying to always close the gap, and the big difference between Aboriginal and non-Aboriginal people with kidney disease. And part of doing that is by trying to keep on top of this and check up regularly. Some people do get symptoms when their kidneys don't work, and they can be very variable. People might just feel crap. They might feel very tired. They often lose their appetite. They might be getting up more at night to go to the toilet. They can have very high blood pressure. They might be itchy all the time. So they're things to look out for, but usually they don't happen till later. And kidney disease is a big problem. So we talked about what is chronic kidney disease, but 10% of Australians probably have it. And about less than 10% of those people know they've actually got it. And one of the big things, the other big thing that's good to remember from this talk is that if you have kidney disease, you are very, very high risk for having heart disease. So if you think about someone with kidney disease, I want you to remember every time, if they've got kidney disease, they could very well have heart disease. And that's really important because the majority of people with kidney disease don't die from their kidneys failing and ending up on dialysis. They die because they have a heart attack. So just like people that smoke have a increased risk of having heart problems, having kidney disease is the same. It's like being a smoker. It means that you're much more likely to have a heart attack. And so that's why it's really good to find out who these people are, because we can actually prevent heart disease as well as kidney disease if we pick them up. That's another thing I'd like you to remember from this talk. Heart and kidneys go together, really important. And if we look at chronic kidney disease in Indigenous Australians, you can see that a large percentage of them have kidney disease, and much higher than people that aren't Aboriginal. And as we've already said, this is a pie graph, and just to go through it for everyone, it's showing the different causes of kidney disease that lead to people being on dialysis. So their kidneys have failed, and those nephrons we talked to have all been damaged. So you can see in Aboriginal people, nearly 70% of the reason people end up on dialysis is because of diabetes. Okay, about 7% is high blood pressure. And for you guys to remember, most of the people with diabetes have high blood pressure as well. So diabetes and high blood pressure in Aboriginal people is responsible for probably about 3/4 of the people that are on dialysis. The other reason people end up on dialysis, and that's not really the focus on this talk, these two letters here, GN, that means something called glomerulonephritis. So they're unusual, rare immune conditions where someone's kidney attacks itself. They're responsible for about 10%. And then PKD is something called polycystic kidney disease. That's a disease that's inherited from parents to their children, and it's a problem where the kidneys become full of cysts and they stop working, and that's inherited, a bit like diseases like haemophilia. And so that's a very small percentage in Aboriginal people, and then other causes of just weird and wonderful stuff that we don't need to go into. So I think it's important as well to go, well, who are these people that are at risk for kidney disease? Because if you don't get symptoms from it, how do we actually know who are the people we should worry about? And these are the groups. So any diabetic, anyone with diabetes, it's important to think, well, they've got diabetes, could they have kidney disease? Anyone with high blood pressure, anyone with heart disease, because as we said, remember, kidneys and hearts go together. Anyone with family history of kidney disease in the family. Now, again, when I chat to my Aboriginal patients, a lot of them will say to me, oh yeah, my mum was on dialysis, her sister was on dialysis, my son's on dialysis. So sometimes that's a really strong indicator that there's something in the family that means they're more likely to get kidney disease. So knowing about the family, and again, as you guys as health workers, you often know the families, and that's really important information. People sometimes are interested to hear just being overweight puts you at higher risk for kidney disease. That's really important to know about as well. Smokers, the reason that causes kidney disease is because, as I said at the beginning, the kidneys they clean about 180 litres of blood a day. And the way the kidneys get the blood is two big blood vessels. If you smoke, the smoking can clog up the vessels that go to the kidney, and you get kidney disease. So smoking's a big risk factor, and unfortunately, just being over 30 and Aboriginal is a risk factor for kidney disease. Now, that doesn't seem fair, and patients will say to me, that's not fair. Just because I'm Aboriginal, I'm at risk of kidney disease. And look, that's a complicated reason why that is, and we don't know exactly why. It's probably related to things like birth weight, and also Aboriginal people only having a Western diet for the last 250 years, and their genetics aren't suited to that sort of diet. But any Aboriginal person is at risk of kidney disease. So again, any Aboriginal person that you come across that has diabetes and smokes, then you think, well, this person could easily have kidney disease. And the last one there is a history of acute kidney injury. That means people that get really sick for whatever reason. They might get COVID, they might get a pneumonia, they might have a heart attack, and they might get admitted to hospital. If those people in hospital get really sick and dehydrated, they can end up getting damage to their kidney just because they've been really sick. So again, anyone that's been sick in hospital before who has had kidney problems in hospital, they go on to have risk of getting kidney disease. Well, how do we pick it up if you don't get symptoms? So we talk about this kidney health check, and again, it's something really simple you can say to patients. Has the doc check your kidneys? And we usually want people to do that every 1 to 2 years. And for anyone with diabetes or high blood pressure, we want them to do it every year. And that is a blood test, a urine test, and a blood pressure check. And again, you can work out the people that you think really need it. So as I said, if you've got a patient that's Aboriginal, who's 50, who's got diabetes, who's got high blood pressure, whose mother was on dialysis, who hasn't had a kidney check for 5 years, you can say to those people, you really need a kidney check, and then that's a really good way of keeping on top of things. We've talked a little bit about this measure of kidney function. I think the important thing for you guys to know is it's called the GFR. Anything below 60% isn't normal. And you may have heard the other term, creatinine. Creatinine and GFR are both what we use to measure kidney function. I talked as well a little bit about protein in the urine and not being normal. So people shouldn't have protein in the urine. Part of the kidney health check is where we check for protein in the urine, and we do a special test called an albumin creatinine ratio. Okay, and that tells us if there's protein in the urine. And if there's protein in the urine, and it's on a couple of tests across 3 months, we can say, yes, they've got evidence of kidney disease. So that's another simple test we can do. Ideally, that test is done on a morning sample, but you can see the red box down the bottom. They said, don't worry about it if it's not a morning sample, just do it, because if it's high a few months, then we know, look, it's definitely real and they've got protein in the urine. The reason the protein gets in the urine is because, as I said, the kidneys are the filters. The filters aren't working properly and they let things in from the blood that they shouldn't, and that's protein. A lot of patients will ask you, oh, is that like protein in my food? Should I reduce the amount of protein I'm eating in food if I've got protein in my urine? I think the answer to that is no. It's a different sort of protein, so don't worry about how much protein's in your diet. What's a normal level? Again, this can be complicated, and there's a lot of doctors that don't know this, but I think for you guys to know, anything really above 30, the number 30, is a lot of protein in the urine, and that's when we say they've got a lot of protein. So normal is less than about 3. Abnormal is anything more than 3, but if it's above 30 on a couple of samples across a few months, that means they've got protein in the urine. And we've talked about what chronic kidney disease is, but we also grade how severe it is. So we have different stages. And the two things I'd like you to remember about this is that the way we stage how severe the kidney disease is, number one, what their GFR is, and number two, how much protein is in the urine based on that urine ACR. And then we can put them into a category of what stage kidney disease they have. So you can see this picture on the right-hand side, you know, and that puts them into the different stages. So if we look at someone with stage 4 kidney disease, that's someone with a kidney function with their GFR between 15 and 29. And then we can look at how much protein they have. And if they've got a lot of protein in the urine, we say they've got chronic kidney disease stage 4 with lots of protein in the urine. And they use this traffic light system here because if you've got someone with a lot of albumin in their urine and they've got kidney disease 4 or 5, they're immediately what we call red. That's worry. You know, they're at high risk of getting worsening kidney disease and ending up on dialysis. If you get someone here that has kidney function between 60 and 90%, but a little bit of protein in their urine, we say, oh, that's just someone to watch. They're a little bit of a worry, but, you know, we need to keep an eye on them. So that's what this diagram means. And this is a more complicated way of doing the same thing. If we look under kidney function, we've got the different stages where my arrows are, stage 1, 2, 3, and 4, and how much protein on that urine albumin creatinine ratio there is. And it's simple that we go, okay, they've got lots of protein and they've got a GFR that's 15. That puts them at very high risk of getting kidney disease. Now, you guys can get an app from Kidney Health Australia that lets you put those numbers in and it will pop up where they lie on that graph and whether you need to be worried, because all the patients that are in red need to see a kidney doctor. And they're the patients we worry about. So GPs use this all the time and you guys can use it as well. And you know, I think this all comes back to, well, why do we want to stage it? Why do we want to know? And it's because we want to pick it up early, prevent people ending up on dialysis, closing the gap, reducing heart disease, because as we said, the kidneys and heart go together. So if we can pick up people with kidney disease, we pick up people with heart disease, and we can mean that they don't have heart attacks, and we reduce people dying and ending up on dialysis, which is the aim of the game, really. And as it says here, if we pick up people earlier, it reduces their risk of ending up with kidney failure or having a heart attack by between 20 and 50%. So there's a huge gain in doing all this stuff. So the next thing we were going to do is just go through a little case study, and I encourage you guys that we're going to do an online poll to see what you guys think. And again, there's no right answers. This is all about what you guys think and learning about kidney disease. So this is Doreen. She's 47. She lives up near Cairns, a nice warm part of the world. She was born in a remote community and she's Aboriginal and she has 3 kids. She's a health worker and very busy being a full-time mum. And she goes to the GP, just doesn't feel right, and she wants a checkup. So the doctor gets a bit more of a history. She's gained about 10 kilos in the last 5 years. So if you remember, we talked about being overweight as a risk factor for kidney disease. She's a smoker. Again, that's a risk factor. Her family have diabetes. And again, that's a risk factor. She had a normal pregnancy, and that's really important because people that have complications in pregnancy, like high blood pressure or diabetes in pregnancy, put them at a higher risk of kidney disease down the track. But she didn't have any problems. She doesn't drink much. She's never been in hospital, so we can say, oh, look, she's probably never had what we call acute kidney injury, and she's actually not on any medications. We examine her. She weighs 91 kilo. Her BMI is 33, and just to remind you, anything above 25 is overweight, and anything above 30 is what we call obese. Her blood pressure is 165 on 100. And we can talk about that in a little bit, but I just want you to think about that and whether you think that's too high or not. She has a normal examination when we look at everything else, and her blood sugar is actually 11.5, which is high. And again, have a think about that and what you know about diabetes, and whether you think that's a bit of a worry. So we've already talked a little bit about cardiovascular disease, and if you look at kidney disease and cardiovascular disease, they're responsible for about 66% of deaths in Australia. So really, really important to know about. So I think this is where we were going to do the poll, and I've been told it should just pop up. So is Doreen at high risk of chronic kidney disease? What do people think? So we're getting some responses in. It's looking really good at the moment. Had 7 people respond so far, a couple via the chat. And it's an overwhelming yes, which is excellent. Yeah, I completely agree. And I think that's because, as we were saying, and this will be on the next slide, she's a smoker. She's probably got diabetes because she did that blood sugar test, and anyone with a random sugar above 11.1 has diabetes by definition. She's overweight, and she's Aboriginal, so she certainly is high risk. So you guys are really on the ball, and that's excellent. So again, if you come across a woman like that in the community, who hasn't had a kidney health check, you can say, look, I think you really need a kidney health check. And let's look at her risk factors formally. So diabetes not diagnosed, but probably has it. High blood pressure, yes, you remember her blood pressure was 160 on 100. That's high. And we'll talk a bit about blood pressure targets in a little bit, but that's far too high. She's obese, she's a smoker, she's over 30 and Aboriginal. So she has 4 risk factors, so it's highly likely. And just remembering about high blood pressure. So again, high blood pressure damages those things called nephrons because it damages the blood vessels. But when the kidney doesn't have as many filtering units and it needs more blood to clean, it sends out actual hormones to raise the blood pressure, which seems silly, but it's a vicious cycle because the kidney thinks, I'm not getting enough blood to clean, I need more. So it'll release hormones to push up blood pressure, and that damages the kidneys even more. So it's a vicious cycle having high blood pressure and kidney disease. And then just looking quickly at smoking, there's been lots of studies looking at smoking, and it's certainly associated with not only the GFR dropping, but also having more protein in the urine, which is a risk factor for worsening kidney problems. And then obesity, we already talked about. And as a doctor, I've found that trying to tackle people with weight problems is really difficult, and it requires persistence and patience. And now there are some great drugs for diabetes that make people lose weight. So we've got a few things up our sleeve. But again, it's always good that we know about this so we can talk to patients about it. If we don't know and they don't know about their kidney disease, then we can't address these things. For people who are Aboriginal, the recommendation is really it should be part of their annual health check. And in people over 30, they should get a blood test and a urine test every couple of years. And kidney disease, diabetes, heart disease, again, they're a triad. They go together. So it's always important to think of all three at the same time. These graphs, probably, I don't want to overcomplicate things, but again, it's just saying basically, if you have kidney disease, your risk of dying of heart disease is very, very, very high. And I think if we remember back to, 1 in 10 Australians, or 10% of Australians will have chronic kidney disease. 1 in 3 Aboriginal people have chronic kidney disease. So that's much, much higher. So that's really important to remember, that unfortunately being Aboriginal puts people at a significant risk of having kidney disease. And this is a little bit about heart disease. So she's got high risk. So here again, we look at a bit more of Doreen's test. So Doreen's seen the GP, and they've said, look, she's high risk for kidney disease. Let's do a kidney health check. So let's look at the protein in the urine. We've got an ACR there of 238. And I think if you remember that number of 30, anything above 30 is high. She didn't grow any bacteria in the urine, so we don't think she's got a urine infection. Her GFR is 40. So if you remember, GFR less than 60, anyone less than 60 to think about. Her hemoglobin, or her blood count, is 104. Her sugar is 13. And she's had actually an ultrasound of her kidneys. So the kidneys look normal and her bladder's normally emptying. And the reason we do that is because we want to make sure that the structure of the kidneys looks fine. So next poll. What's your management plan for Doreen? And you can select any of these. Is it lifestyle advice on smoking, nutrition, physical activity, weight? Encourage Doreen to take medications, attend medical appointments with Doreen, take part in follow-up with the educator, follow her up every month, checking in, see how she's going, or all of the above. What do you guys think? And you can all answer. It's anonymous, remember, so, as I said, there's nothing wrong with having a crack. I think it's pretty obvious, this one. My tip always to people is, if there's an all of the above option, it's usually that one. And that's what everyone's going with. So spot on. We want to treat all these things and be sensible. So I think, we take a holistic approach and try and tackle all these things. So that's great. Everyone's on the ball there too. And look, it says here, are there other tasks you could perform to support Doreen? Again, you guys are going to know much more about that than me, but I think this is a really good start. And really what they're getting at there is, keeping an eye on things and getting us sent to a kidney doc if needed. Now, all those parameters she had, certainly a good GP can manage that. As a kidney specialist, we usually will see patients once their kidney function drops below 30%, or they're getting rapidly falling kidney function. So it might go from 70 to 50 to 40 in a couple of months. So we would see those people too. And other things to focus on with her: blood pressure, because she had high blood pressure, trying to reduce protein in the urine, thinking about new medications for diabetes that are all the rage at the moment. You can see one there written SGLT2 inhibitor. You guys might have seen that medication called a Forxiga, or there's one called Jardiance. They're really good diabetic medications because they reduce protein in the urine, which is what we want to do. They treat diabetes. They lower cardiovascular risk, and they also lower the risk of someone ending up with kidney disease, or their kidney disease getting worse. So they're magic drugs, and we really want as many people on them as we can. They've only been around for about 5 years, and you'll see more and more diabetic patients getting put on them. They've talked here a little bit about her anemia because she's a little bit anemic. They've talked about making sure she doesn't have too much acid in the blood. And she's a way away from needing dialysis or anything, but just to plant that seed that your kidneys aren't going too well, and there's some things we can do to look after them, to try and get people aware of their lifestyle and what they can do to prevent their kidneys getting worse. So for lifestyle, they talk about SNAP, which is reduce smoking, improve nutrition, avoid alcohol and physical activity. So, the common sense stuff that we say for anyone really, whether they've got kidney disease or not, it's good that if everyone did that, we get them to stop smoking, trying to get them to reduce their BMI or their weight. Again, that if anyone's got a magic way of doing that, I'd love to know. It's really hard, but the simple things of exercise and eating less. It's easy to say that, and it's harder to do it. Low salt diet. Again, in a Western diet, we eat far too much salt. And again, Aboriginal people have been on the Australian continent for tens of thousands of years, evolving on a diet that was based on, bush tucker and low salt. And in the last 250 years, salt has come into the game, and the genetics of Aboriginal people aren't used to salt in the diet. So trying to make people aware of salt and reduce it. Soft drink isn't there, but I try and make sure people are not drinking sugar-laden soft drink like full-strength Coke. Staying active, reducing weight, all that stuff that just to reiterate. And here are all the ideal targets. We talk about a BMI between 18 and 25. So we want salt, no more than 2 grams of salt or sodium in the diet. I don't know if anyone's tried that, but it's pretty tough. But once you do no salt for a couple of weeks, you actually get very sensitive to salt, and it's very salty when you go back. A DASH diet, that's a specific diet that was developed to reduce people's blood pressure, and it really focuses on fruits, veggies, and reducing total fat. Physical activity and no more than 2 drinks per day for men and 1 drink for women. And next to all those recommendations, you can see how much that reduces blood pressure by. So if someone did all that stuff, they could get their top number of their blood pressure probably down by about 15 points. And we don't focus enough on that as doctors. We just give tablets, but it's something you guys can certainly emphasize, that this is the stuff that actually helps with diabetes and their heart disease by doing all this stuff. And this dinner plate thing's a really good way of remembering how people's plates should be made up. At least half with fruit and veggie, about a quarter with protein, and about a quarter with grains and carbohydrate, because poor nutrition is linked with all those diseases in those blue boxes: dementia, osteoporosis, heart disease, stroke. So again, this is the simple stuff that we don't pay enough attention to. So blood pressure targets. This is another pop-up box that we'd like you to have a think about. What blood pressure target would you treat Doreen for? Now, if you got a bunch of different heart and kidney doctors, they'd probably come up with different answers. So this isn't a straightforward one, but see what you think. Just in the interest of time, guys, we might move on. We had, it's about 50-50 between 120 on 80 and 130 on 80. Really good, and they're the 2 ones I would say. And I could talk for hours about which one it should be. The answer they're going to give you is 130 over 80. That is what the guidelines would recommend, that anyone with chronic kidney disease, we want to try and get it below 130 on 80. Now, the important thing to remember with all of this is that it depends on the individual. If you have a frail 85-year-old with the same blood and urine tests, you'd probably say, oh, look, it should be 150 on 80 at best because I don't want them falling over. If you have a 25-year-old who's active and fit and works full time, I would say definitely 120 on 80 if possible. So it really depends on the patient. And being a kidney doctor who sees a lot of kidney disease, if I think a patient can tolerate it, I'll try and push them a little bit lower. For you guys to remember, 130 on 80, 120 on 80, that you did really well with those numbers. And I think you clearly know that they're the right targets. But, you know, if someone has no kidney disease, no heart disease, is a fit person otherwise, we would say 140 on 90. But these people are different because they're at risk of progressive kidney disease. So we want to be more aggressive. And as I said, if you've got a young patient who's got kidney disease, I'd go even lower. But that just depends on the feeling from the patient. So again, as a practicing doctor, blood pressure management is something that's not done very well because it's just done sometimes when patients see doctors. It's often not done. It's hard to know what it actually is when they're seeing a doctor. It's hard to know what it actually is when they're at home. And people forget that it's usually you don't get symptoms with high blood pressure. So high blood pressure isn't a disease, it's a risk factor for getting stroke, heart attack, kidney disease. So because it's silent, a lot of people don't even care that their blood pressure is 180 on 100. They're like, oh, is that high? I don't feel any problem, so I don't really care about it. So really good to ram home to people, no, the number is very important. We want it at 130 on 80 if you've got kidney disease, because we know if it's higher, your kidneys will get worse and you'll end up on dialysis. So, you know, I have some patients that are on 7, 8 medications for their high blood pressure because we're really trying to keep it low. So this is Doreen again. So Doreen's made some progress. So she's lost a little bit of weight. She's down to 5 cigarettes a day. Her kidney function has gone off a little bit, but she was started on a blood pressure tablet. Her potassium level has gone up a little bit. Her urine protein has gone down a little bit from 230 to 140. She's a little bit more anemic now. You can see that her blood count's gone from 104 to 95. She's got good iron and B12 and folate stores, and they're the if you think about anemia for your blood count, you need iron and B12 and folate to make blood, to make hemoglobin. It's a bit like you need concrete and bricks to build a house. You can't have one without the other. Her blood sugar is much better, and her blood pressure is actually a little bit better as well. And there's a question here. Her kidney function has declined since the first visit. She's been put on a blood pressure tablet. Do you think that's a concern? Are you worried about that kidney function going down? Let me just go back to it. I'll just see, did they say what they put her on? No. But it's gone down from 40 to 34 a month later. Are you worried about that? Do you think it's a problem? I've got 3 responses. Might wait just for a few more. Again, it's all anonymous. Please answer. It's good to get your brain thinking about this stuff. It's probably bored listening to my voice. So most people have put yes. And look, I think it's good to be on the ball about this. It's a bit of a tricky question. I don't think it's a very fair question, but it's actually no, because she was put on a blood pressure tablet, and those blood pressure tablets initially will cause your kidney function to drop a little bit. But I actually think it's good for you to be worried and to think about it. So that's a bit of a tricky question. I think if you were worried about that drop, you just say to her, look, why don't you repeat the blood test in a week just to see how things are going? But really, because she got put on that blood pressure tablet, we usually expect the kidney function to drop a bit. But again, I wouldn't expect you guys to know that, because often as a doctor, I'd probably be a little bit worried and just make sure with a follow-up blood test. And then we've got a 3-month visit, and you can see on the 3-month visit, her weight's much the same, her cigarettes are the same. Kidney function is very similar, and that's the important thing I think about that last question. GFR, glomerular filtration rate, it's an estimate, and it can fluctuate on blood tests between 2 blood tests. It can be 40 one day and you do it a few weeks later, it can be 35, then you can do it a few weeks later, it can be 37. So it's about the trend over time. Her potassium is what I would say a little bit on the highish side. Above 6 is high. She's sort of hovering there. Her protein in the urine has continued to come down. She is a little bit more anemic. Her blood sugar control is actually pretty good, and her blood pressure is slowly coming down, not to that 130 on 80 target, but we're getting there. And if we put Doreen in a category, she would, we were talking about this graph at the beginning. She's stage 3B, and she's got significant protein in the urine. So that's where you would say that she sits for her kidney disease. So she's someone in the red light traffic zone, or someone to be concerned about, certainly. And that's what's really good about this CKD in primary care action plan. They'd put her on what's called a red clinical action plan, because she sits in the red bit, and they say you've got to investigate the underlying cause, which we think is probably diabetes, assess her cardiovascular risk, avoid kidney drugs, drugs that affect the kidney function, manage complications. And there you can see at the bottom, referral to kidney doctor. And then in the red, which is where she's, prepare for kidney replacement therapy, I would say when appropriate. She's still a way off that. And prepare for supportive care if she doesn't want dialysis, which probably wouldn't be appropriate in her. So she probably should go and see a kidney doctor. So what are the most important things to focus on for her management? Again, a tricky one. So this is more of a group discussion thing. I'm not sure there's a poll as such, but is it to stop her smoking, get her diabetes better, get her blood pressure better, reduce her weight, encourage good lifestyle, assessing her bone health, because we said at the beginning, kidneys are important with your bones, or manage her anemia. What do you think should be focused on? It doesn't look like that's a poll, but look, I'm not really trying to teach you guys how to suck eggs. It's pretty obvious that it all gets managed, really. So I think, and that's why these patients can be complicated, because you got to, in a busy GP clinic where they're only seeing them for 10 minutes, they can't address all these issues. They have to focus on one and say, okay, well, look, her diabetes is a bit of the main problem at the moment. Let's get her on the right tablets. Let's see what her blood pressure is doing. And it's about chipping away and constant review, reminding patients. Patients forget this stuff. They may not have the health literacy of understanding it, so they need to be told reminders and explained to it in simple language. And that's where I think you guys are so important. I'm guilty of it, and I know a lot of my colleagues are as doctors, that we often use doctor language to explain stuff, and patients genuinely have no idea what we're talking about. So really important to use patient-friendly language that's going to resonate with them. This is again the action plan, really useful thing on an app, which I encourage you guys to get, because again, you can plug in all the numbers and go, oh, you've got really high risk for kidney disease. Have you seen a kidney doc yet? And then you can even make those suggestions to the GP if they haven't done it, because again, it's about everyone's responsibility of getting these patients managed properly. So what about Doreen? What do we think will happen to Doreen? And this is often why I get sent patients. I'll get sent a patient like Doreen, and the patient say to me, well, what's going to happen? Am I going to end up on dialysis? And it really depends on how good we are at getting blood pressure control and diabetes control. For Doreen, I would want an HbA1c, that's that 3-month measure of diabetes, at 6.5%. I would want her blood pressure at 130 on 80. I would want her BMI to be between 18 and 25. And that's why we see patients regularly, to see how are we going doing that. And she gets referred to a kidney doctor like me. The reason that's good is because evidence shows that it reduces the risk of the patient ending up on dialysis, because they're getting watched, they're talking about these things all the time. And they're planned for dialysis if that's what's needed. They don't just rock up to the emergency department with a kidney function of 5% and need urgent dialysis, but it's a planned thing. So I'll see patients and say, look, unfortunately, you're going to need dialysis. Let's plan you for dialysis and start it in a safe environment when you're not admitted to hospital, but we just say, look, it's time to start. And then we know them, so we can start thinking about kidney transplant early and get them a kidney transplant. So that's why it's really good to refer these patients. And you can see here, this is just a summary of who should be referred. Anyone with a kidney function less than 30, anyone with lots of protein in the urine, anyone whose kidney function has dropped more than 25% within 12 months, or more than 15% in a year, or anyone that has kidney disease that just has really hard to control blood pressure. As a kidney doctor, I often see patients whose blood pressure just won't come down. And a scary fact is those patients, often it's because they don't take their tablets, but they don't tell anyone. So about 50% of patients that have what we call resistant high blood pressure is because they actually just don't take their tablets. So again, that's something simple you guys can do. Say, look, are you definitely taking your tablets? Because your blood pressure is still really high. They don't need a referral if their kidney function is stable and above 30%, or they don't have protein in the urine and their blood pressure is good. And again, all this stuff, these are guidelines, but you can use your common sense. You know, if it's someone that has kidney function above 30%, but you know they smoke, they're Aboriginal, they're all their family members were on dialysis, I think it makes sense that they see a kidney doctor. And then you guys can, again, as we said, really contribute to self-management, people taking responsibility for their health. And this is just a little bit about health assessments and the billing item numbers. And there's stuff for that on MBS Online. Probably run out of time, but this is just about the different types of dialysis. You guys, again, probably know this. These pictures are actually from the Menzies group up in the Northern Territory that tried to make patient-friendly, Aboriginally, culturally appropriate information for patients in remote communities. Again, freely available on the Kidney Health Australia website, and really good because it puts dialysis into context for Aboriginal patients. You know, maybe not as relevant for Western New South Wales Aboriginal people, because this was specifically made for remote community Northern Territory patients, but still it might be a better way of explaining it for people than complex sort of lots of words on the page. And then this is just the things to take home. It's CKD is a silent disease that is probably more prominent than you realise, and that it's much more common in Aboriginal people. And if we're ever going to close the gap, we need to identify those people and get their management in early. We stage kidney disease with what is called their GFR and the amount of protein in the urine, because that allows us to work out what is this person's risk of their kidneys getting worse in the next few years. And if it's really high, they need to see a kidney doctor. Assess for complications related to kidney disease, and think about, is this patient at risk of kidney disease, and should we be checking their kidney function? You can get this handbook for Kidney Health Australia. You can get a free digital copy. You can get this CKD Go app that I was talking about, which is fantastic. I've got it on my phone. It's really useful, and I know a lot of GPs use it. It's really user friendly, and I encourage you guys all to get it. And thanks again for participating. Thanks for asking me to talk. And I'm not sure if there'll be some sort of survey, but I'll leave that up to Erica.
James, I'd just really like to say thank you so much for your time and your expertise today in going through what seems really complicated and complex and breaking it down for us all. So we really appreciate that today. I also thank everyone who's given up their time to attend today. It's really wonderful to see you all dial in. We will have the slides and the recording link sent out to you next week. And if you can all just take a moment to scan the QR code that's on the screen at the moment, and do an evaluation. It really helps us know any further learning needs you have, and what we can deliver for you moving forward. So it's been really lovely having you all join us today, and I hope you all have a lovely afternoon. Thank you so much.
Thanks all. Thanks for joining.